It involves elective initiation by various means, performed only for a specific medical or obstetrical indication. And what is the augmentation? There are two terms. Augmentation is a different thing. It refers to enhancement of spontaneous contractions when inadequate. So to increase the frequency, duration, and intensity of contraction after the onset of spontaneous labor, and it is during failed cervical dilatation and fetal descent. So we are talking for labor induction. It is seen that more than 500 women die annually due to labor-related complications, and about 4 million fetuses are stillborn annually in developing countries. In developed countries, the proportion of infants delivered at term following induction of labor can be as high as 1 in 4 deliveries. Perinatal mortality rate in India is at an alarming 22 per 1000 live birth, and prevalence of induction is up to 22% in India. Induction of labor, they refers to actually adoption of any method which initiate uterine contractions, and modern fetal monitoring tools contributed significantly for assessing fetal well-being in utero, and advances in neonatal care also contributed in salvaging life of fetuses delivered preterm and reducing incidence of IUD. So labor induction artificially needs more vigilance than spontaneous and associated with more chances of instrumental delivery of cesarean section. So now the question comes, when we can induce labor, can we induce in all patients, or there are certain indications? So when perception that continuation of pregnancy poses an increasing risk to maternal or fetal well-being and benefit of terminating to mother or fetus outweigh the advantage of future continuation, then induction of labor is done. So its indications are, we all know, maternal illness, hypertension, diabetes, hypertension, SLE, premature rupture of membrane, antepartum hemorrhage, maternal request, of course not routine, fetal post-maturity beyond 41 weeks, fetal growth restriction, oligohydramnios, intrauterine fetal death, luteal phase malformation, unstable fetal life. But of course we should know the indication, but we almost always rule out contraindication before inducing any woman, and that is contracted pelvis, transverse lie, pelvic tumor, placenta previa, previous classical cesarean section, severe placenta insufficiency, heart disease, active genital herpes, adderley primi, ART high risk. What happens during induction of labor? Induction of labor occur in stages or as a stepped approach. It is common for induction of labor to take 2 to 5 days even from the start of induction to the birth of your baby. Step 1, like first there is a preparation or softening of the cervix, that is called ripening. Step 2, there is a breakage of the bag of water around your body, and that is called ARM or artificial rupture of membrane. And then the stimulation of contractions within, and it can be done also with an oxytocin tip. So what is the cervical ripening? It is often the first component of labor induction. To facilitate the softening and thinning of the cervix, there is a series of complex, there is a biochemical processes which leading to rearrangement and realignment of collagen fibrils of cervix, changes in the glycosaminoglycan composition, increased cytokine production, and white cell infiltration. So these biochemical changes occur in the cervix under the process of certain hormones, certain prostaglandin, and this is called the ripening of cervix, and it is always necessary before dilatation of cervix. So we have to induce this, we have to do this when we want the induction of labor or we want to deliver a fetus. And the determination, there is a ripening, it is determined by Bishop score. It is usually dichrotonized into the favorable or unfavorable. So we all know the Bishop score, I am not going in detail. So this is very important part to assess the cervix before choosing the case for the induction of labor, as well as choosing the medication for the induction of labor. So as you all know that before dilatation of cervix, there is a need the cervical ripening. So what medicine we can use it? We all know there are certain mechanical methods, they are without side effects and they are sometimes very useful, especially in the scarred uterus. So like membrane striping, mechanical dilator, hygroscopic dilators, laminaria tent, Foley's balloon catheter, and extra amniotic saline infusion. And some are not very common, but some are we are using. And the surgical methods, amniotomy, artificial rupture of membrane, it can be always used. And the medical methods we all know, the drugs which can initiate which can helpful in the ripening, that is oxytocin, prostaglandin, dinoprostone, misoprostol, mifepristone, nitric oxide donor. So cervical ripening and induction of labor after prior cesarean birth, it is always we want to know and we want to remain ourselves updated. So here I want to tell you that patients who are planning for a trial of labor after a previous cesarean, that is also called TODAC, they must give birth before the onset of spontaneous labor, as it might increase the risk of uterine rupture. So risk factor for rupture during induction, factors that have been associated with an increased risk of rupture during induction induction. After a previous C-section, there are no previous vaginal birth, unfavorable cervix, unuse of prostaglandins, especially like misoprostol appears to be associated with a higher risk for rupture than induction with oxytocin or cervical ripening with mechanical method followed by oxytocin administration. So prerequisites and assessments before doing the induction of labor. First, we have to take the informed written consent from the couple, and we have to tell about the all indications, all the consequences, all the side effects, all the adverse effects related to the induction to the mother and fetus. Review of maternal history and profile. You see whether that woman is eligible for induction, it can be done or not. Evaluation for indication and rule out any contraindication. I have already told you. Reliable estimation of gestational age, presentation and fetal weight, maternal pulse, blood pressure, temperature, respiratory rate and findings on abdominal palpation, they all should be recorded. Evaluation of baseline fetal heart rate pattern by auscultation, electronic fetal monitoring, maternal pelvis assessment. This is a very important part, and clinical evaluation for possible CPD of fetal-pelvic disproportion. You have to check it before keeping the patient on the induction. Assessment of cervical status using modified Bishop scoring system to predict the likelihood of success and select appropriate method for induction of labor. Indication for induction and gestational age along with modified Bishop score. This should be documented at the time the decision for induction of labor is made. So this is very important. Our all staff should be trained for this. And once we keep that patients and the prognosis and chances of success, they have to tell that women also and to our staff. So these are the factors for successful induction of labor, like period of gestation, pre-induction score, cervical ripening, sensitivity of uterus, presence of fibronectin in vaginal swab if it is done, and other positive factors. So common methods for induction, we all know non-pharmacological is typing, amniotomy, traditional method, castor oil, nipple stimulation, but pharmacological we are now using dinoprostone, misoprostol, oxytocin, mifepristones and others. So mechanical methods, it is not very much popular and not first line because of risk of infection, but of course it is uses with other methods, so it is helpful, and especially in the scarred uterus for the ripening of the cervix as well as for the dilatation, and there is no chances of hyperstimulation because of this. So this is the good method, and catheter balloon it is mostly used. It is a cost effective also. Then different method for induction, I have already told you, balloon catheter, prostaglandin gel. So recommendation before induction I have told. So others dilators like hygroscopic dilators, they are sometimes used, but they are not always it is successful in doing the ripening and always not successful in doing the induction. So besides that, cervical balloon catheter I have already told you, and membrane sweep. It involves a clinician detaching the membrane from the lower uterine segment by circular movement of examining finger, and I am just emphasizing this very simple and non-side effects method, because sometimes we forget to do this simple thing that is helpful for the success of induction of labor, and it thought to lead an increased production of prostaglandin. Amniotomy, we all know that it has to be done whenever we are doing the induction if cervix is adequately dilated for the progress of labor. Drugs for medical induction. Now comes, we all know that there are certain drugs like prostaglandin E2 and prostaglandin F2 alpha, misoprostol, oxytocin. So how they help and what is the general principle that in which case which drug should be used. So it is WHO recommendation that induction of labor should be performed only when there is a clear medical indication for it and the expected benefit outweighs potential harm. Induction of labor should be performed with caution since the procedure carries a risk of uterine hyperstimulation and rupture and fetal distress. Whenever induction of labor is carried out, facilities should be available for assessing maternal and fetal well-being. Women receiving oxytocin, misoprostol and other prostaglandins, they should never be left unattended. Failed induction of labor does not necessarily indicate cesarean section. So now come to the very important medical method of the ripening of cervix, that is the dinoprostone and E2 gel. So this is the endocervical prostaglandin E2 gel. It is a very commonly available. We are using it the most preferred for cervical ripening, especially in the scarred uterus, and it causes do the collagenolytic properties and sensitize the myometrium to the oxytocin. So it is useful in the poor Bishop score, can be repeated after 6 hours, no antidiuretic effect, and but it requires refrigeration. On the other hand, other PGE1, that is another prostaglandin that is used as a misoprostol, we all know that it is used in the term pregnancy or near to term 25 micrograms or vaginally or orally. It can be stored at room temperature. It is its advantage, cost effective. Incidence of hyperstimulation, of course, course, if it is given with the sublingual, it is seen more, and it has to be given judiciously in the scarred uterus, or even the WHO don't recommend in the term pregnancy scarred uterus misoprostol. In IUD, definitely it is preferred. When Bishop score is less than 6, then of course amniotomy done if cervix is adequately dilated. Oxytocin infusion, it is a less effective when cervix unfavorable. But biometric sensitivity, it starts from the 20 week of gestation for oxytocin and maximum at 34 weeks of gestation. Mostly used for augmentation other than induction of ripening. Hyperstimulation is guarded as because we can stop infusion. Prolonged use may cause water intoxication and it needs refrigeration if it is keeping for a long time. So, but always remember with any induction inducing agent, electric fetal heart monitoring along with partogram, they should be strictly followed to monitor clinical progress of labor and to detect emerging maternal and fetal complication at earliest. So what are the risk of induction of labor? Of course, it can be failed. To decrease the failed induction or to minimize the failed induction, we have to be expert and we have to be used very judiciously, proper inducing agents, proper monitoring, as well as proper pre-induction assessment. So consequences, hazards could be failed induction, prolonged labor, ascending infection, placental abruptio, uterine tachysystole, uterine hypertonus. Means there is increased uterine contractions more than 2 minutes, and tachysystole means tachycardia. In it both together, then it causes a hyperestimulation. Electrolyte imbalance, postpartum hemorrhage, uterine rupture in prior uterine surgeries, multiple gestations, grand multiparity, hyperemia. And fetal hazards, of course, fetal distress, hypoxia, low Apgar, fetal stress of operative birth, hyperbilirubinemia, risk of birth trauma in cases of assisted delivery. So how to manage the complications of inducing agent? In hyperstimulation, oxytocin has to stop immediately, to give the patient left lateral position, oxygen, and tocolysis, they can be tried. In amniotomy, engagement of fetal head has to be confirmed to avoid the cord prolapse. As far as control membrane rupture should be done in hydramnios cases, and fetal heart rate monitoring just after doing the procedure if baby is live, it is required. Now failed induction, if happened, then what to do? Either repeat induction or cesarean depending on the clinical assessment. Incidence of emergency cesarean section rate is found to be higher in patients undergoing induced labor as compared to spontaneous. So what is the Indian experience on induction? There is a study they conducted comparing obstetrical outcome following induction at 40 and 41 week of gestation, where both groups were induced with intracervical PGE2 gel. And it is said that cesarean rates were higher in the 41 weeks, 30% as compared to higher in the 40 as compared to 41 week, but asphyxia, MSL, meconium aspiration syndrome for the worsening perinatal outcome in 41 week was significantly higher. So, study compared misoprostol versus dinoprostone gel for induction of labor. It is said that misoprostol group and dinoprostone gel for induction, mean time for labor induction, it was less in the misoprostol group, 43 minutes as compared to 1 hour 40 minutes in dinoprostone. Duration from induction to active phase, it was also less in the misoprostol group, 1 hour 42 minutes as compared to 4 hours. Dinoprostone group, active phase to delivery time, it is also less, 3 hours 6 minutes. In the misoprostol group as compared to dinoprostone, 4 hours 52 minutes. Induction to delivery interval 5 hours 2 minutes, that was also less in the misoprostol group as compared to around 12 hours, around 11 hours in dinoprostone gel. And cesarean section rate was 6% in the misoprostol group and 22% in the dinoprostone group. So this was the study one where this is the compared. Another study where the efficacy of PGE2 gel like dinoprostone in labor induction, it was seen that if PGA2 gel during the ripening, it causes the spontaneous labors after first dose. That is in the 92% cases it is successful. Failed induction in 1.33%, mean duration of latent phase in the 10.34% cases. Induction delivery time is 16 and cesarean section rate 17%. So PGE2 gel is a good modality for inducing as well as for ripening agent, but again the case selection should be good. Oxytocin induction, in one studies it is given to all patients and it is says that in 90% cases the vaginal delivery was done in that particular study, but it is seen that if the Bishop score is 0 to 4, the failed induction is at 28% cases in comparison to 5 to 8 Bishop score 6% and more than 9 failed induction in nil. So like of course the Bishop scores matter for the success of induction of labor. Induction delivery interval is also also less. If the Bishop score is more than 9, then it is 8 hours as compared to 15 hours in the 0 to 4. Role of mifepristone. Induction with mifepristone is though controversial. Not studies was accepted by Cochrane's, but one study that was done with mifepristone 200 milligram. This is effective for ripening and induction in IUD mainly without adverse reactions. And different mifepristone, they some are using in the IUDs 200 milligram. Others, the different mode of misoprostol. We all are familiar with the induction with misoprostol. So it is oral and vaginal misoprostol when compared for the induction of labor. So it is seen with vaginal misoprostol, hyperstimulation chances are little higher than oral misoprostol. It is 1%. And again, another aspect, oral misoprostol is a good. So induction in the special condition like prolonged pregnancy, it is definitely associated with higher success rate after induction. Perinatal complication and maternal complications are higher, so patient has to explain the risk of 41 and 42 week of gestation in absence of spontaneous labor. Now, premature rupture of membrane. If rupture of membrane close to term, then induction should be done after 24 hours of draining in absence of spontaneous labor. If it is less than 34 weeks, then definitely should be delayed till lung maturation or unless fetal distress or chorioamnionitis. Risk of maternal complication and perinatal complications are higher in form of sepsis in cases of especially PPRM. So patients should be counseled, good NICU facility should be there, and one has to remain vigilant. In cases of intrauterine fetal death, of course, mifepristone followed 200 mg followed by vaginal E2 or vaginal misoprostol. They are the agent of choice. And what is about the dose? Then definitely in intrauterine fetal demise, the first dose in 13 to 17 weeks, you can give the 200 mg and the 6 hourly PV. 4 doses can be given, maximum not to exceed 1600 microgram. And the cases previous LSCS, the dose have to be done the half the dose, and careful monitoring is required. And in the 20 to 26 weeks, you have to give 100 microgram 6 hourly per vaginal, and more than 26 weeks, always you have to give misoprostol. That is 25 micrograms to 4 hourly, and you can use the 6 doses. But again, not to exceed 600 micrograms and half the dose. And again,